Hey guys, haven't forgot about you. Been pretty busy. Want to do an overview of calciphylaxis and the two subtypes. We do have some new members to the page and to our group. I do want to preface all of this with always follow your physician's recommendations. They are physicians for a reason. But do be your own advocate and your loved one's advocate. And if you have questions or want to present research or something that you think may help, do so, but make sure it's from reputable sources. So that's what I want to say first. Also, I want to know how everybody's doing. Been saying prayers for all of you that are currently suffering from calciphylaxis, and I'm saying prayers for the loved ones that are helping you through this. As a person that has witnessed a loved one go through calciphylaxis, it takes a complete toll emotionally, spiritually, as well as physically from lack of sleep because of worry and everything else and researching a rare disease. Fortunately, the disease itself is very poorly understood. There's not a lot of research out there, and not many people know about it. So with my mom's experience, for those of you that are new, my mom was diagnosed with calciphylaxis, and her subcategory was CUA, which stands for calcific arteriopathy. She was diagnosed with that back in 2017. It started to present itself again in January of 2018, and unfortunately, we lost my mom in April of 2018 from complications of calciphylaxis. So calciphylaxis, there are two subcategories for those of you who don't know. Calciphylaxis is just the broad term. The two subcategories are CUA, which my mother had, the calcific arteriopathy. Yes, that's a mouthful. And the second one stands for non-uremic calcifications. So let's start with CUA. CUA is prevalent in patients that are end-stage renal disease or kidney transplants. Mechanism isn't truly understood, but they do see a high prevalence of patients who have either been on Coumadin therapy or hyperparathyroidism in conjunction with the ESRD, as well as getting calcium-based phosphate binders is increasing the chances for CUA in conjunction with vitamin D therapy. So they have found that there's a high prevalence of patients that have had any of those, that they have a higher risk of developing the CUA. So CUA, for my mom anyway, how it presented with two hard nodules on both inner thighs. They were extremely painful to touch. If her legs rubbed together, she was in excruciating pain. And that's how she presented in 2017. They did a tissue biopsy to look for calcifications in the subcutaneous tissues, as well as the adipose tissues, and they did find calcifications, as well as looking at her lab work and seeing that she had a high phosphorus level, as well as a high calcium level, and also she had a her PTH, her parathyroid hormone level, was through the roof. So with all those, they came to the conclusion that she did have calciphylaxis. So the treatment for my mom and what they did, and the gold standard for treatment for now with ESRD patients, is aggressive dialysis. Following dialysis, they start sodium thiosulfate infusions, and that's supposed to help with those calcifications. As far as pain management, narcotics for my mom didn't really work, and through several conversations I've had with multiple other patients, narcotics haven't worked very well for them as well. I've done some research. I have talked to a few physicians who have done nerve blocks to help with the pain, as well as prescribed medications like Lyrica or gabapentin, which is good for nerve pain. In conjunction with that, using like a lidocaine jelly actually in the wounds as well to help with that. Something my mom did that they said, if it helps, then use it and do it. She would put ice packs on the area. So then 2018, this year, she presented the same way, and then they quickly developed into what looked like blood blisters, but it wasn't. It was actually calciphylaxis progressing and getting worse. By the time all was said and done, my mom's legs bilaterally, almost from ankle to upper thigh, were completely necrotic. And necrosis, for those of you who don't know and that are new and haven't heard my spiel before, necrosis just means tissue death. And necrosis, you can tell that it's necrotic because it'll be a black, leathery looking area, and that is necrosis. So what is causing that? I am sure that's one of your questions. So what's happening is calcium and phosphorus bind together, and they deposit themselves in the small arterioles, or the small blood vessels underneath the skin, and it inhibits blood flow getting to that area. It's pretty much occluding that blood vessel, and so that area of tissue is no longer getting the oxygenation it needs, and therefore it creates wounds, and non-healing wounds at that. So let's go to NUC, the non-uremic calcifications. These patients are not end-stage renal disease patients. They are not dialysis dependent. You see a high prevalence for NUC patients in Caucasian women. Why? Don't know, but they do. They see a high prevalence in Caucasian women. The second thing is hyperparathyroidism. Another thing they have seen is obesity or extreme weight loss for these patients. For NUC, you guys, those patients, they're even less prevalent than a CUA patient. So there's even less research for you guys. Again, sodium thiophosphate is a gold standard treatment for it. And for both CUA and NUC, aggressive infection control is definitely something else. Another treatment, and most of you probably wouldn't think of it, you're probably thinking more of like physical treatments, but you have to have a good diet. And one of the factors that they see is if these patients have low albumin, their wounds are not going to heal. Albumin promotes wound healing. Albumin is produced by the liver. It is a form of protein, and you get it from eating protein, and it helps with the production of collagen. So if you increase your collagen production, you will increase the likelihood for these wounds to heal. Another predisposing factor for both of those are also diabetes. Moving on, there are different, so CUA patients, there's a shake called Nepro. It's approved for end-stage dialysis. Sorry, got a phone call, didn't mean to interrupt. So Nepro shakes, it's got protein in it, it's got all the necessary vitamins and minerals that are necessary. Sorry, I just got another call, and I apologize. So there's another, for both NUC and CUA patients, Better Protein. It's a powder. It comes in a small square packet. You can put it in applesauce or a little bit of fluid if you are an end-stage dialysis patient, because you do have to watch your fluid restrictions. So you don't want to drink too much. You need to follow your fluid restrictions as strict as possible. Any doctor will tell you that. Also, there's another supplement out there, and it's called Juven, and Juven is to help promote wound healing, and I read an article where that can also be used for the NUC patient as well as the CUA patient. So moving along, we talked about how my mom presented, reading the several documents that I have read, speaking with the several physicians that I have spoke to. That is the typical presentation: hard nodules that are painful to the touch. Areas that are more apt to develop these wounds are adipose-rich areas. And what's adipose, you're asking me? Adipose, it's fat. That's plain and simple, it's fat. So fatty areas, your calves, your thighs, your buttocks, your abdomen, your underarms. For women, breasts, yes, men can develop calciphylaxis. It's just not seen as much as it is in women. And men can develop it in their genital area as well. Something else, like I said, the mechanisms aren't truly understood, but they have found a link between calciphylaxis and trauma. So there is controversy out there. There's several different articles, some that say you need to surgically debride these areas, other articles that say, well, if you debride it, it creates trauma to good tissue by taking away the bad tissue, and you could, in fact, cause the calciphylaxis to spread or worsen. So that's controversial. For my mom, they did maggot therapy, and I know the word maggot probably makes you all want to vomit. But it actually really helped. They debrided that area without disturbing any good tissue. So that is a treatment that I don't think many people think of, but thank God my mother was at a hospital that thought to do larval or maggot therapy. So that's a non-invasive way to treat that. There's other conversations and other controversies about amputation. Again, you're creating trauma, so it could or could not, 50-50 chance, that it could make the calciphylaxis progress. In my mom's case, they absolutely would not take a knife to her. They felt that it would just be more detrimental to her. I do have an example of where trauma did make it worse. My mom was dropped at one of the facilities. I'm not going to say names. They physically dropped her, and they caused a 6-inch laceration on her left lower calf. Mom's original calciphylaxis wound was up on her left upper thigh, and when they created the trauma to her left lower limb, the calf, it then caused the calciphylaxis to then spread, tunneling all the way up to her left original wound on the upper thigh. So that was an instance where trauma did create the calciphylaxis to become worse. And very unfortunate for my mom and our family. That drop was extremely detrimental and is what ended up taking my mother's life. Sorry, I'm getting choked up. She was on the road to recovery. She had new tissue growth and everything with everything that they were doing. She was on up and up, and then that fall happened. So trauma is linked to worsening of calciphylaxis. So we talked about sodium thiosulfate, aggressive dialysis, good nutrition, protein especially to increase that albumin. If you are a renal dialysis patient, we have been told by physicians, my mother's physicians, she was on like 16 Tums a day, and Tums equates down to calcium acetate. It's calcium based, but it can be used in dialysis patient as a phosphate binder. Well, in the presence of calciphylaxis, you want to stay away from calcium rich anything. Well, Tums is calcium rich. So in my mom's case, the fact that they put her on Tums, 16 of them a day, increased her calcium serum levels in her blood, just making the calciphylaxis worse. We talked about some pain management therapies. Like I said, narcotics didn't really work for my mom very well. There's been several people I've talked to that said, we're on 4 milligrams of Dilaudid every 4 hours and Oxycontin and, whatever other narcotic you want to throw out there, and they're still screaming in pain. Nerve blocks, medications like Lyrica or gabapentin, those help with nerve pain. So when these wounds start getting deeper, it's creating nerve damage. So, hi, Robin. Hope Mark's doing well. Praying for you guys. Love you. So when these wounds are getting deeper, it's causing nerve damage. And so those medications like Lyrica or gabapentin is going to help with that nerve pain. And then the lidocaine jelly, you can put that actually directly in the wounds. Some other treatments out there, hyperbaric oxygen chamber therapy. It literally is what it sounds like. It is a chamber. It's a negative pressure chamber, and it's pure oxygen. And that helps promote these wounds to heal. There is a very stringent requirement form of what patients have to meet. They have to meet certain criteria. They can't have certain health disorders, because if they do, that can knock them out of getting hyperbaric therapy treatment. But it's good to mention to your doctor if they're not doing hyperbarics, see if your loved one or yourself is a candidate for hyperbaric chamber therapy. Talk about larval therapy if they don't want to aggressively get in there and clean out these wounds. Infection control, because that is the highest prevalence of mortality for this patient. These wounds open up and then infection gets in there, and unfortunately it'll go to the bloodstream. Once it goes to the bloodstream, that is then considered sepsis, and sepsis is highly fatal. That is typically what these calciphylaxis patients die from, and that's their mortality, and it's from secondary infection, not the calciphylaxis itself. Somebody reached out to me and asked me, can calciphylaxis attack organs? There's a very small percentage, but yes, it can, but it hasn't been seen very often. I think it's been like 1 in 100,000 of calciphylaxis patients that it's actually affected the organs. Like I said, hyperparathyroidism, so a parathyroidectomy is also another treatment. Mom did receive this. You have 2 little parathyroid glands that sit around the thyroid, and they typically leave 1/4. And the reason why they leave 1/4 of that gland is to still maintain your blood levels at a lower than normal range, but they still want you in that normal range. They don't want you too low, they don't want you too high, so they want you on the low spectrum of normal. So that's why they leave that 1/4 of the parathyroid gland. And then I had somebody else ask me, what was the question? I don't remember. If I remember, I'll come back to you. But anyway, so I just wanted to do this overview for those of you who are new. I want to welcome you to our page and to our group. Please feel free to contact me at any time. If I do not have an answer, I will do my best to get you an answer. I have several physician friends. I have physicians I'm in contact with from all over the country. I'm dying for as many answers as you guys are about this disease. Gotta spread awareness. It's gotta be a team effort. I need help. I can't do it alone. Please share the video. If you haven't already, please like and follow the page. You will find a group that is linked to the page. I do invite everybody, even if you're not a sufferer or have a loved one suffering from calciphylaxis, if you're willing to offer moral support, prayers, love, good vibes, fingers crossed, whatever, you name it, please join our group. These people that are suffering and the loved ones that are watching their loved ones go through it, it's extremely difficult, and I can speak that from firsthand experience with my mom. You can talk to my sister, you can talk to my dad. It's extremely hard. So moral support, keeping hope alive, and positive attitudes. I'm sorry, getting choked up again. Positive attitudes are truly a good thing. There is several studies out there about people who have terminal diagnoses, and positive attitudes lead to positive outcomes. Again, I can't stress enough to be your own advocate and advocate for your loved ones, because if you don't do it, nobody else is going to do it. Don't be afraid to ask questions to your physicians, and don't be afraid to present research. But again, make sure that research is reputable and not WebMD. No WebMD doctors. And lung, heart, and abdomen calcified vessels are marked, though. Do you know anything other argan or citrulline? Keeping the faith. Yes, Robin, keep the faith. I'll ask about those two medications for you. I've never heard of them. I have heard of falafalin. I don't know if that's related to one of those medications. Yep, and don't be afraid to fire them. You can fire doctors. Yeah, Robin's right. You can fire them. We did it plenty of times. And I think my dad's on here. We fired plenty, didn't we, Dad? But please, help me spread the awareness. The non-for-profit I started is official. I just have not had the chance or the opportunity to start any fundraising. The goal now, I have a federal tax ID number, but I want to try and get the foundation recognized nationally. So that's my next step. I'm not stopping. Robin can verify that once you're affected, whether you're the loved one or the patient from this disease, it's a faceless monster, and all you want is justice, answers, and people to do the research and know what the heck they're talking about, because you get sick of educating everybody when they say calciphylaxis. So that's the whole point of me being on here. I'm trying to educate. I'm trying to spread awareness. Please help me out. Share the video, like the page, follow the page, and request an add to the group if you're willing to be of moral support. Like I said, you do not have to be suffering from this, nor have a loved one suffering from this in order to be added to the group. I don't think I have anything else right now, unless anybody has questions. I saw Robin, I'll get you that answer. I'll get that answer somehow. But Dad, if you're still on here, if you can think of anything. Are you still on here, Dad? Do you have anything to add? I'm trying to think what else they did for my mom. Intense aggressive wound treatment. They did Meta Honey. That was one of the things they did. And like a Silverdine gel. Silverdine, they typically use for burns, but they use that as well too on her, because that can be wound healing promoting factor. Oh, team approach. That's what I wanted. That's what I wanted. The person that messaged me asked me what kind of doctor do they need to have. Well, I guess in general, if you're a CUA patient, which is the calcific uremic arteriopathy, which happens in end-stage renal dialysis patients or kidney transplant patients, you definitely have to have a nephrologist on board. But this is a systematic team approach. So an internal medicine doctor, vascular surgeon, dermatology, infectious disease doctor to keep that infection risk down, a nutritionalist that can help with the diet and promote getting more protein in the diet to increase that albumin, which then in turn, what does it do? Promotes collagen growth and promotes wound healing. So you definitely need that. And then maybe general surgery as well. And I'm sure there's others, but those are the ones on the top of my head. Oh, and another risk factor for the NUC subcategory that I forgot, and I'm getting tongue-tied, is liver disease. I have found several articles that has linked NUC to liver disease. So I think I'm going to wrap that up. I don't think anybody has any questions. Again, please like, share, and follow our page. If you haven't already, invite yourself to the group if you have positive vibes to share. And definitely please like and share this video to get awareness out there. People may not know what in the heck calciphylaxis is until they see this video. And again, those of you who have been with me throughout this journey know it's my mission till my dying day to bring more awareness, more education, and make this disease in the forefront. We need no more calciphylaxis to anybody. Much love, prayers to everyone, and as I end every video that I ever do, my contact information is 618-791-9590. That is my personal cell phone. You're more than welcome to use it 24/7. Robin will tell you that if I can't answer right away, I will call you back. I will get a hold of you. We also have an email. It's Linda Strong, LINDASTRONG Calciphylaxis @yahoo.com. You can reach me through email as well. Or if you don't want to get a hold of me through those two methods, you can Facebook message me through the Linda Strong Calciphylaxis page, through the group, or you can friend me and message me on my personal Facebook page as well. That's it. I love you guys. Many prayers, and we will catch up soon. Bye.